Started. All right. Good morning, everyone. Thank you for joining us for the colloquium here. So today we're hosting Professor Margaret Brandeau, all the way from Stanford, visiting us from the Bay Area. And a lot of excitement out there. Professor Brandeau has a lot of accolades. She's done a lot of work in population health, looking at HIV, homelessness, opioids, infectious diseases, the list goes on. She's an Informs Fellow. She's won Pierce Scala twice, as well as many other prestigious awards. And today she'll talk to us a little bit more about her research using smartwatches, and we're very excited to learn more. So without further ado, take it away, Professor Brandeau.
Thank you. And thanks a lot for inviting me. It's great to be here. Surprisingly, I'd never been to Madison, but it seems so far living up to its reputation as a really nice place. Anyway, so today I'm going to talk about some work we've done on using smartwatches to improve personal and population health. Check out the animation. Very nice. I chose this topic for a couple of reasons. I know people like Jonathan and others are thinking about ergonomics and reminders and smartwatches, so I chose it for that reason, but also because we're using some industrial engineering tools like control charts and simulation. So there you go, a little preview of why you should like this talk. A little bit of background. I've been working with colleagues from Tel Aviv University in Israel for the last 5 years. We had funding from the Koret Foundation to just do research projects together. And so one stream of our research projects that we've been working on is using smartwatch data to improve personal and population health. So I think many people in this room right now are wearing smartwatches. I see one on O's there. Right, there's a growing integration of this technology into our life. It's estimated that about 30% of people in the U.S. regularly wear a smartwatch or fitness. There's Jeff, he's got his. Regularly wear a smartwatch or fitness tracker, which is interesting because like 5 years ago, about 20% did. So more and more people are wearing smartwatches and the like. Well, that's kind of nice because smartwatches provide lots of data. Like well, my picture isn't too good, but basically it's showing information about this person. It looks like it's about their run. But right, they provide us with lots of health data. For example, physical activity, right? A lot of people, I know I've used mine for this, like, did I get up and walk enough today? So steps, distance, calories burned. Information about your heart rate. So your heart rate variability, lots of things like that. Some smartwatches can tell you about how many breaths you take per minute. Typically, they tell you about sleep and some estimate of how good or bad your sleep was, how interrupted it was, as well as some smartwatches will also tell you about stress. Stress can be measured by heart rate variability, but also things like skin temperature and other things, and heart rate even. So we can get lots and lots of data from smartwatches. So many people have, of course, started thinking about how can we use this data. So, for example, it's used for activity tracking and fitness optimization. I'm sure many people use them for that. I know I use mine to try to keep myself honest about the exercise. Heart rate and cardiovascular health, many studies have been done trying to think about how we can help people with that. Some smartwatches will actually can do an electrocardiogram and measure your blood pressure, so we could monitor that. Of course, sleep monitoring and improvement. Very typically, people who go to sleep clinics, they're wearing this watch, and we want to find out, how is your sleep after we had this intervention? Some interesting apps about stress and mental health insights, emergency alerts and fall detection. One of my students told me, the other day my car crashed, and before I could even call 911, my Apple iWatch had already called them. Like, I started a call and I saw the first responders arriving. So certainly we can use it for that kind of thing. But what we're asking in our study, so lots of different things. What we're asking is whether we can, how can we use smartwatches to detect whether you have a communicable disease and then to control the spread of communicable diseases. So that's the general area we're looking at. And I'm going to look at studies that address several different questions, as I'll explain in a minute. But let's just look about what happens when a person gets infected. So you're hanging out and somebody coughs on you. You catch this infection. And I might add that the infections I'm going to talk about today are communicable respiratory diseases like COVID, influenza, strep throat. So you don't have any symptoms, fine. And then, people develop symptoms. I'm terribly sick. Then maybe you go and get some tests, do a COVID test, or you go and your doctor tests you for strep throat. You're sick, you realize you've got this communicable disease, maybe you stay home, or you stay home some of the time. And then hopefully all goes well and you recover. Of course, so that's a typical course, but not everyone has symptoms, right? We've had, when COVID first came out, people realized, this person had COVID and never had a single symptom, right? So there's also people who go through this process who they're infected but never have any symptoms. So the research questions, so keep this flow in your mind as we go. So the research questions we want to ask are, how do individuals behave without smartwatch detection? When can smartwatches detect an individual's infection? And to what extent could smartwatches control infection spread? So I'm going to talk about two studies today. The first study, we had data on from a clinical trial of 5,000 people in Israel for 2 years, which I'll talk about in a minute. But basically, we want to just look at the data and find out how do people behave when they get infected with disease and communicable infectious disease, and when could smartwatches have detected their infections. So that's the first study, just a data-based study. And then the second one is a modeling-based study saying, okay, so now I have some information about when the smartwatch could have detected your infection. What might that do to the spread of this infection? So 2 different studies. So let me jump right into the first study that's answering these first 2 questions. So I have been working with a colleague from Tel Aviv University in Israel, as I mentioned, and this is a prospective 2-year study. It's actually going on more than 2 years, but 2 years, nearly 5,000 participants. Every participant was given a Garmin Vivo Smart 4 smartwatch, okay? So they're all wearing the same smartwatch. So that was like part of the incentive to be in the study, get a free smartwatch. But then our colleagues developed an app that is specific to this clinical trial, and they fill out a daily questionnaire about their health. How do you feel today? How's your mood? Do you have any symptoms? Have you been diagnosed with any of these diseases? So they're filling out daily questionnaires. And then we also have all of these individuals' electronic health records. They all belong to the Maccabi Health Services HMO in Israel, which I think is the second largest HMO in Israel. So this is super cool because we have 3 streams of data about these people for 2 years. So we have lots and lots of great data that we can use. So in this particular study, we've done other studies using this data, but in the one I'm going to talk about, we're looking at 3 different diseases: influenza, both pandemic and seasonal; COVID, 3 strains of COVID, the original, the strain, the Delta strain, and the Omicron strain. And then group A, streptococcus, which I'm going to abbreviate GAS, but it basically means strep throat, okay? So we're going to look at 3 diseases, and we're going to, this is just kind of an overview. We know who got infected with these diseases because we have they can do home testing or get tested at their doctor. They can report it in the app, and we have their electronic health records. So we know who got infected with these diseases, and we know who didn't, or we don't think they did. So we created case and control cohorts for each of the diseases so we could study. And then we want to look at, let's look at changes in behavior and biomarkers during the whole time from when we think you're exposed to when you get tested, okay? And I'll explain about that in just a minute. And then what we want to do is look at the so-called digital incubation period. That's the time when the smartwatch can detect your infection, because normal incubation period is the time from when you get infected to when you have symptoms. Digital incubation period is when you get infected to when the smartwatch knows you're sick, okay? So let's look at these key time points. So a person gets infected, as I mentioned. They may get symptoms or not. They may get tested, okay? So the incubation period, this is just standard in disease modeling, is just the time from when you get infected to when you have symptoms. The diagnostic decision period, we just call that as the time from when you get infected to the time when you get tested. And so for all the patients in our cohort, we know when they reported symptoms, and we know when they reported getting testing. But the other thing we want to look at is not just their self-reports, but we also want to look at when the smartwatch could have detected the infection. I've put it to the left of symptom development because it turns out it's earlier than when people actually think they have it. And so we're going to call that the digital incubation period. So that's what we want to examine from our data. How long is the digital incubation period? How long is the incubation period? And how long is the diagnostic decision period? And my preview is your smartwatch knows you're infected before you do. But let's see how that works out. So I mentioned we had a clinical trial. As you always do, we have a clinical trial profile. I think about 11,000 people showed interest in participating in the study. Then after they talked to the people on the study team, 7,600 were interested. We had nearly 5,000 active participants by October 2023. Now, I mentioned some people got flu, some people got group A streptococcus, some people got COVID-19. Some of them got it more than once, okay? So we have in our sample, we have 490 cases of flu, 320 cases of group A streptococcus, and 2,206 cases of COVID. So for each person who got infected, so some people got infected multiple times, but for each person who got infected, we found a control individual in the population who was sort of matched by age and sex, okay? So, and who didn't get infected. But you see these numbers are a little smaller. I hope you can see that. It's kind of small, sorry. So for example, we have 490 influenza case reports, but 453 controls, because there were only 453 people who got infected. Some got infected more. But anyway, so we're going to look at people who got infected and people who didn't, because we want to make sure that we're not just finding things that happen to everybody, that only happen to people who are infected. So that's why we have a control group. So I mentioned about the data. We have lots and lots and lots of data. So we have self-reported daily questionnaires that where people tell things about their mood, their stress, their sleep, their symptoms. Did you get vaccinated? How much sport did you do? Different things they can enter. We're not going to use all that data. In this study, we're basically using the test time, the test results, and self-reported symptoms. So for these different diseases, did you get tested? When? What was the result? What are your symptoms? Okay. We also have the Smartwatch data, and again, it's telling lots of things: heart rate variability, oxygen, sports, like movement and stuff, and sleep. And I believe in this study, we're going to look at heart rate variability stress, steps, distance walked, active time, and active calories. Now, let me tell you a little bit about heart rate variability. This seems to me counterintuitive, but it turns out when you're physiologically stressed, like you're sick, your heart rate becomes less variable. I thought it would become more variable, but it becomes less variable. So the Garmin has an algorithm that takes your heart rate variability and creates a stress measure that just tells you your body's stress level. So that's what that is. Okay, so this is the data we're going to use. So we want to estimate the incubation period and the time until testing, and then we want to estimate the digital incubation period. So let me tell you a little bit about our methods. So for each person, we identified the earliest time they got tested, when they reported their first symptom, and then we estimate when they were exposed to the disease. Now, the way we do this is for many diseases, people have actually done controlled trials. I don't know if you've ever seen this. It's kind of funny, but they'll take like 20 undergrads and and give them the flu and then see how long till symptoms develop. Seriously. So any of you students who need money, I don't know. But that's what they do. So that's how they find out how long it is from when you got it. Because you don't always know, right? When you get sick, you're like, I think I got sick the other day on the plane, but you don't know. So they've actually done studies. So what we do is we don't know when people are infected, but we just work backward from the time of symptoms and say however much time. So we assume the maximum incubation period reported in the literature. So 4 days for flu, 5 days for COVID, 5 days for strep. And then we work backward. So that's how we estimate the incubation period. So that's all pretty straightforward because they tell us when they had symptoms and they tell us when they got tested. So that tells us time until testing, time until symptoms. But what about the digital incubation period? How do we do that? So we're going to find out when the smartwatch could detect the disease. Now, I mentioned we're just using 2 measures from the smartwatches. There's other data, but we found these were easy and reliable and actually told when people were infected. So I mentioned we have lots and lots of data. Oh, we have so much data. The students, if they were here, they'd be crying, telling you how long it took them to clean this data. But we calculate average heart rate measures in 6-hour windows, and then for 2 weeks before and 2 weeks after estimated exposure for each person. And here's about the stress measure. In case you have this kind of smartwatch, it'll tell you how stressed you are. And then for each person, we calculate the differences in the measure, right, for the exact 6-hour window from 2 weeks before. So we're going to compare you before infection with you after infection. And then we're going to aggregate it over all infected individuals. And then I mentioned we're going to use control charts. We're going to use X-bar charts to identify when there's an anomaly in either of these measures. And we're going to use 3 standard deviations, okay? So that's what we do. So here's an example for influenza. This is actually from the supplement of our paper. So this is an X-bar control chart for heart rate. And although I don't have it labeled, these are hours, okay, hours over time. These are for all the people in my cohort. I think, what did I say, 490 people had flu, whatever. For the 490 people, here's the average heart rate over time. And then I've got some control limits. Now, usually in an X-bar chart, the control limit is a flat line. It's varying slightly here because I have different numbers of observations. Okay, that's why I've got a little wiggliness in my control chart. But basically, here's my X-bar control chart for heart rate. And so what I would say is, well, I've gone beyond 3 standard deviations, actually here. But when have I gone beyond 3 standard deviations? And we have the same thing for heart rate variability. And so here's the time, the first anomaly for heart rate, and it happens that I believe for this particular one, the anomaly for heart rate variability was at the exact same time. But so that's how we do it. That's how we figure out, can the heart rate detect the anomaly? Now, one interesting thing is one of the reviewers of our paper said, maybe you could do something different where you could do segmented regression. So in this particular picture, what I'm showing you is mean difference in heart rate from the 2 weeks prior. So up and down, up and down. And what you could do is you could say, there's no difference because I'm not yet infected. And, things have not yet really happened to me. And so you go up to here and you fit a flat line, and then from here you fit whatever linear line works. And then you can just work your way through every single potential point at which you want to have the anomaly change. I guess I already said that. So you fit a segment with slope 0 and then another segment. So we did that, and so this particular one is mean difference in heart rate. So this is the value from the X-bar chart. This would be the value that minimized the mean squared error. It didn't work as well, and the problem with this is you can't use it in real time. This is a post hoc analysis, whereas control charts, you can just say, let's see what's happening with this person. But I just put this in as an interesting aside as a way you could think about anomalies. Anyway, so as I mentioned, we use the X-bar control charts to figure out when you're infected. So let's look at the results then. So let's go through that. So for influenza, what I'm showing you here in the top graph is mean difference in heart rate, and in the bottom graph is mean difference in heart rate variability. And this is for patients with influenza. And so I've aggregated over all patients, the difference between you 2 weeks ago, okay? So mean difference in heart rate, and then I'm showing the controls. I'm showing the controls to show you that, there's something happening here. These controls are just, yes, everyone has variability, but basically the controls are flat, but you see that we're working backwards from this estimated time you got infected, which was 4 days before symptoms or 5 days depending on the disease. So what we have here, and we know when people are tested, so this is our diagnostic decision period. We know when people have symptoms on average, so that is our incubation period. And then we have our digital incubation period when our control charts tells us there's an anomaly. Okay, so that's how we figure out the digital incubation period. Now, one thing to mention is that the heart rate and heart rate variability might have anomalies at different times. There's nothing that says they have to be the same. So we just assume whichever one is sooner is when the digital, when the watch can detect your, I think in this case they're the same. But so when we do this, we find out that the mean time for people with flu from when they have symptoms to when they do a flu test is 39 hours. I'm also showing you confidence intervals because we have a big sample. The mean time from smartwatch detection unto symptoms is 73 hours. So you can see that the smartwatch can detect the symptoms quite 3 days before you have symptoms. And so this is with real people and real infection. So it's saying, I could tell you, if you're wearing this smartwatch, I could tell you, you may well have a disease 3 days in advance, and you should get tested. I can't say what you have, but I could say you should get tested. We did the same thing for COVID. Exact same chart. So what we found out from this one is people waited about 53 hours from symptoms to testing, and the smartwatch could detect it approximately 1 day in advance. Okay. Similarly, for streptococcus, exact same charts. Time from symptoms to testing was about 38 hours, and the time from when the smartwatch could detect it was actually 62 hours in advance. So the point is, the smartwatch can detect it well before the person can. So that's quite interesting. The second thing we looked at, remember I said we have the physical activity data from the smartwatches? We looked at how many contacts people had. I'm sorry, this one was from self-report. They told how many contacts they had every day. So so I'm using the same color scheme I used before, which is, this is when the smartwatch could detect it. This is when the first symptom appears. This is when you get tested. And this is for the 3 diseases. So what we found out is that people really only reduce their contacts after testing, not after symptoms, and not, obviously, smartwatch detection, because they didn't know about that. So that's one thing. But you do notice here that I believe people with COVID reduce their contacts after testing significantly, okay? So that's good to know, I guess. Okay, the other thing we looked at was physical activity. This was from the smartwatches. And basically what we found out is that physical activity decreased the most, again, on the day of testing. So you got tested, so you had less physical activity. Okay, so let's summarize what we found out from this study. So there was, first of all, significant delays from when people developed symptoms and got tested. And as we saw behaviorally, they didn't really change their behavior that much until they did get tested. But so for flu, it was 39 hours, COVID 53, strep 38 hours. I mentioned that, right, your smartwatch can find out through heart rate anomalies that you have something happening, some kind of infection happening in your body. And, excuse me, significant amounts of time before you know that. And people only change their behavior later. Okay, so, you know, our study clearly has some limitations, and I feel like as scientists, we better acknowledge what those are. We don't know the time and date of exposure. The time of symptom onset is based on participant self-reports. Maybe they didn't respond till the next morning or whatever, so we don't know exactly. Influenza diagnosis was basically participants did their own testing, so how accurate was that? Gaps in smartwatch data collection. We don't necessarily have full data, like someone takes their watch off to charge it. And then, of course, each individual is different. We have averages and confidence intervals. But nonetheless, we have some conclusions from this study, which we published in Lancet Regional Health last year. Basically, smartwatch detection and patient self-testing can play a really important role in containing infectious diseases. And really, the question that comes from this is, well, if we use smartwatches to detect infection and get people to change their behavior, could we eliminate epidemics? So that is what our second study is about. So now I have some data about detecting early. Maybe we could have a model of what might happen. So that's a second study. And the question we looked at, excuse me, is the impact of smartwatch detecting on a communicable disease epidemic, again, respiratory communicable diseases. And in particular, we're looking at whether the reproduction number of the epidemic could get below 1. So in case you don't know, reproduction number is the average number of new infections that an infected individual causes. And it's quite interesting. It varies significantly for different diseases, right? We're seeing a measles outbreak right now in the US. Each person with measles, on average, infects 12 to 18 other people. I think measles, I mean, you know, that's just almost unavoidable. If someone you live with has measles, you're getting it. So very high. Chicken pox, also pretty high. Polio, high. HIV, 2 to 5 people. That's an entirely different type of disease, but on average, an untreated infectious person will infect about 2 to 5 other people. Common cold, 2 to 3. Ebola, 1.8. So anyway, so this just gives you a flavor of the infectivity of different diseases. But if each person on average infects more than one person, you're going to have an epidemic. If each person infects less than one, it will die out. So what we're looking at in our study is if we use smartwatches, can we drive this number below 1? Excuse me. So we developed a model that looked, we call it a multi-scale model because we look at viral dynamics within a person and social contacts. So it's within you and you to the rest of the population. And I'll talk about the model in a minute. And as I mentioned, our idea is, well, if we could detect earlier, maybe we could reduce social contacts earlier, and how would that help us? We use a stochastic model, and we just do simulation of our model. I don't think there's anything closed form you could really do here. And for this, we did 3 strains of COVID-19 and pandemic and seasonal influenza. So let me give you a schematic of our model. So on the top, here's what would happen with no smartwatches. Now, I've got symptomatic individuals. These are people who are ever going to develop symptoms, and those who will never develop symptoms. So symptomatic people, and what I'm showing on the x-axis is time from exposure, and what I'm showing on the y-axis is how many other people you might infect. Well, it turns out that, as you may know, infectivity varies over time. When you're not infected, you can't infect other people. Then you start getting sick, you get really infectious, and then you start healing and getting better, and you have less virus to transmit to others. So that's what's happening here. The number of people you can infect is going to somehow be related to the infectivity of the virus within your body. And so for the people who become symptomatic, at some point, they get tested, and they're like, oops, I'm sick, I should isolate and stay home. And so after they get tested, they reduce their contacts and infect fewer people. And that's what typically happens. But of course, if you never knew you had symptoms, and probably you're less infectious, but nonetheless, you just keep living your life, right? Now, with smartwatches, let's say we can detect the infection earlier. Then here, there's my red line from above, but maybe I can detect earlier and thus get you to change your behavior earlier and infect fewer people. And of course, for these people, they never had symptoms, and I'm telling them, oh wait, you have symptoms, so then they can change their behavior. So that's schematically what we're looking at here. So I am going to have a few equations, not too many, and I won't quiz you. It won't be on the midterm, as we say. I'm going to have a few equations just to show you what our model is. So I mentioned about the reproduction number. The way we are going to model this is your infectivity varies over time due to your changes in viral load. So we're going to have different levels of infectivity. So we're going to let I of t be the average number of infections caused by an infected person on day t of their infectious period. How many other people I can infect. And tau is going to be the length of the infectious period. With this definition, then, the number of persons that somebody infects is just the sum. In this case, I'm using discrete time periods. You could integrate if you wish. We had discrete data, so I'm doing it this way. But right, it's just the sum over all the time periods until you get better, until you're no longer infectious, of how many people you infected each day. So that's just the reproduction number. Okay, that's pretty straightforward. I think we all, if this is on the midterm, I think you guys can pass, right? We know this one. Now, I'm going to divide this up into infections caused by symptomatic versus asymptomatic individuals. So I'm going to define the fraction of individuals who become symptomatic versus not, those who just always remain asymptomatic, and I'm going to just define the average number of people the symptomatic versus asymptomatic people will infect. I just basically put some subscripts on these values. So, and then the length of the infectious period for symptomatic and asymptomatic individuals. So I didn't do anything but say I'm going to divide it between symptomatic and asymptomatic people. So we can now just write a reproduction number in this way. Because now what I have is the fraction of individuals who become symptomatic, how long is their infectious period, and how many infections do they cause per day, and the exact same thing for the asymptomatic people. Again, nothing mysterious. Now I am going to do another thing. I'm going to incorporate viral load and contacts. So we know that likelihood of infection corresponds to your viral load. If you have a high viral load, you're going to infect a lot of people. If you have a low viral load, you can't. And in fact, that's what's so interesting about the HIV treatment drugs is they reduce viral load in an individual, if properly done, so low that they can't infect other people. Anyway, so we're going to say that we're going to now write the likelihood of infection transmission as a function of the log of viral load and number of contacts. So we're going to say that the number of people you infect is proportional, and I don't care what the proportionality constant is, but it's proportional to the log of your viral load at time t and the number of contacts you have at time t. So I just rewrote it. And so we can just, again, rewrite our equation that I just showed you. I showed you the equation where I put in the number of people you infect. But in this case now, I'm going to replace the number of people you infect by this expression, the log of an infectious daily viral load and number of contacts you have. And this is a way of tying back your infectivity to things we know, which is the viral load of people over time. Okay, so that's the next thing I've done. And then there's only one more thing I have to do, which is, well, what do smartwatches do here? So now I just said you infect people. I'm looking at symptomatic and asymptomatic people. So now let's look at the effect of smartwatches. So we need to know the changes in daily contacts when there are smartwatch alerts. So let's say there's a smartwatch alert that happens. Well, let me just put both equations. There's a smartwatch alert that happens at a certain point in time, tau bar. This is the time when the smartwatch detects the infection. And this is the reduction in number of contacts. So this is how we're going to model the effect of smartwatch alerts. Now, what's interesting here, I didn't tell you how many contacts people have. I'm going to assume that both asymptomatic and symptomatic people reduce their contacts by the same amount. If they don't, I may need to know more information about how many contacts people actually have. But I don't need to know it in this formulation. So this is changes in daily contacts. So now we can write down the reduction in the last equation, students, okay? The reduction in contacts is just the amount I had the amount of transmission I had before minus my new changes in contacts, which is just multiplied by beta. So number of contacts without and with smartwatch alerts. Because remember that picture I showed you? I found the smartwatch, I found you're infected at a certain time, you reduced your contacts. So that is our model. And we're going to model it as a stochastic simulation. And as I mentioned, we're going to do it for the 3 variants of COVID and the 2 variants of flu. So, so this is our model, and now we just need to think about model parameters. Well, the first thing, I mentioned that viral load changes over time. So and I mentioned that you know, people do studies where they give people the flu and measure their viral load and other things. So there's actually lots of data on this. So we looked through the literature and fitted some curves to what is known in the literature. For symptomatic and asymptomatic individuals, we fitted it with a gamma distribution for each of these diseases. So this is your viral load over time. Now, I think this is better illustrated with a graph, not a picture. So here's for COVID-19 variants. This is the basically probability density function of the log of viral load over time. So, and I think this is in terms of, I don't know what the time unit is on here. Days, maybe? And so this is for the 3 strains of COVID. It's basically showing you become quite infectious and then slowly it tapers off. And similarly, we did it for pandemic and seasonal influenza because they're different influenzas, okay? So that's what's happening here. So, okay, and viral load changes over time. Let's look at some of the other parameters. So the reproduction number can be found in the literature. How many other people does someone who's got COVID, the original COVID, infect? Interestingly, you see that Omicron, you guys may know this, Omicron was much more contagious. It was also much less deadly, but much more contagious, 4.2 average number of people infected. And then for pandemic influenza, 1.65, seasonal influenza, 1.28. We also have information from the literature about the fraction of individuals who remain asymptomatic. So these are people the smartwatches can really help. Now, from the, we also have information about the mean time at which people become symptomatic. Now, from the previous study that I just told you, I already have information about time from symptom onset to testing. And I also have information about the time when the smartwatch could detect it. I think I've got that right. So these two are from the study I just showed you. Smartwatch sensitivity in detecting infection, we had some estimates about how good it would be. And then the last thing, how much do people reduce their contacts? So in the previous study, I think people reduced their contacts by, I don't know, 60-something%. There was also a survey in Israel where they asked people, if you were paid not to go to work, you know, if you have COVID, would you not go? And or how much would you reduce your contacts? And those numbers range from 57 to 95%. So we just assumed, again, it's a model, you can put any number you like. We just assumed people would reduce their contacts from 66 to 75%. So now we have this stochastic simulation model that we can use to simulate what would happen. So we simulated the model for each disease. We simulated 1,000 parameter set realizations. And then we calculated how much R would be reduced due to early smartwatch detection, means and confidence intervals as you can get, and calculate the probability that we can control this epidemic. So we just put these numbers into our model to ask ourselves these questions. So the first graph I'm going to show you is, well, what is the probability? Oh, no, the first graph is estimating the reproduction number with and without smartwatches. So here I'm showing you if there's a 66% reduction in contacts. And I'm showing this for the 3 COVID variants, ancestral, Delta, and Omicron, and the 2 influenza variants, pandemic and seasonal. And the red is the reproduction number. I'm showing whisker plots, but box and whisker plots. But basically, this is showing that for the ancestral COVID variant, if you have 66% reduction in contacts with smartwatches, you still can't get the reproduction number below 1. You can for the Delta variant. You cannot for the Omicron variant. You can for pandemic and seasonal influenza, assuming 66% reduction in contacts. And similarly, you can look at 75% reduction in contacts. Things look better. But again, you still can't get Omicron below, reproduction number below 1. So that's interesting. That's just basically saying, I think I have a thing. If you have smartwatch detection, you could probably get the reproduction number below 1 for the Delta and variant and influenza variants, and maybe for the close for the ancestral variant. Okay, so that's the first thing. Another thing you could ask is, what is the probability the reproduction number goes below 1? Basically, similar massaging of the data. So, for example, I'm showing here with my red dot the time of symptom onset, and the blue dot, and sorry I changed colors on you. In the journal, these are the colors they wanted. This is smartwatch detection. So I'm showing the probability of the reproduction number going below 1. Now in this graph, what we assumed is the reduction in contacts was uniformly distributed between 66 and 75%. So what this is showing is, well, first of all, early detection is clearly better, right? Just by having smartwatches detect earlier, you increase the probability that you can get the reproduction number below 1. Although you see, for example, for the Omicron variant, the lower line here, it's not going to happen, basically, as we say. That's a probabilistic term. It's not going to happen. But for the COVID-19 Delta and ancestral variants, in fact, you have a pretty good chance of reducing it. And remember, this is a function of your viral load over time and how much earlier I can detect it. There's lots of things folded in here. Okay, the next thing we looked at is what would be the minimum required contact reduction. I said that 66, 75%. So in this graph, what I'm showing is the minimum required contact reduction to achieve either a 50% or a 75%. Those are the two dashed lines, 50% or 75% chance of reducing the contact R below 1. And the left graph is for the COVID. The right graph is for influenza. So the required contact reduction, and then the y-axis is the required contact reduction. So what we see here, of course, earlier detection is better, I mean, duh. But also, for influenza, we need smaller reductions in contacts than we do, say, for COVID. For COVID, this is saying if you want to get the reproduction number below 1, even with smartwatch detection, you're going to need 60 to 80% reduction in contacts for these two variants. And for this variant, I don't know, 55 to 60%. Whereas for influenza, you need lower reductions in contacts. So that's also useful information you can get out of this study. One last figure from this study. And for the Omicron, it's infeasible, really. You just can't get people probably to reduce their behavior enough. By the time you've detected it with the smartwatch, it's just too late. One last graph. This is a two-way sensitivity analysis. So what we're showing here is the percentage reductions in R as a function of the time when the smartwatch can detect it, the time from exposure to when the smartwatch can detect it in days, and then the effective reduction in social contacts. And so what this graph is, and I've done it for each of the diseases, the 3 COVID variants and the 2 influenza variants. So one of the things you see here is the contour lines are showing percentage reductions in the reproduction ratio. So for example, 25% reduction here, 35% here, et cetera. What we are showing here is that because these are kind of vertical lines, really what matters is earlier detection, not reducing contacts. These are vertical, so the earlier you detect, the less contact reduction you have to have. So lots of things happening in this figure. Hope it's not too confusing, but that's the conclusion from this. So, okay, so now we have our study. I've told you a lot of things. What can we conclude? And I might add, this is just a theoretical study. We're all wearing these smartwatches. I'm sending you all a text saying, you know, you're probably sick. So here's a few things to summarize. You know, across a number of scenarios, if you have somewhere between 66 and 75% reduction in contacts right after smartwatch detection, you can reduce disease transmission by 40 to 65%. In some cases, that will get the reproduction number below 1. As I just mentioned, earlier detection plays a bigger role than contact reduction. Of course, you have to have population level compliance in wearing the watch and in reducing contacts. Again, this study has some limitations. We use stochastic simulation. There's lots of uncertainty. We're doing our best with the data we have. Well, this is something Jonathan has worked on for sure, but, right, false alerts and alert fatigue, right? There's lots of studies like, you know, your smartwatch is telling you stuff all day long, and maybe you're just tired of that. So you wouldn't want to have false alerts, for example. That would be bad. Of course, reducing social contacts, that's about behavior. And there's lots of reasons why people might or might not want to reduce their contacts. But some, you know, conclusions that we made, right? That earlier detection is a good thing. Another thing you could do, you could consider spatiotemporal patterns of disease. If you knew that the person wearing a smartwatch lives here and there's lots of flu is predominating, then you could say, maybe you have flu. Or if you knew there's a lot of COVID happening, oh, maybe you have COVID. So that might help. I guess I said that. Of course, behavior change is key, although earlier detection is also critical. And, you know, people might not want to change their behavior, and there may be obstacles. I think I mentioned that the study in Israel found out that if you compensate people for lost wages, that could make them more compliant with self-isolation. You know, another interesting thing, I think we could probably apply it to other respiratory infections. I don't know. I haven't really thought this out yet. But so some conclusions from this study, though. Wearable technology could help contain future outbreaks, reduce the need for lockdowns, and even prevent pandemics before we start. Again, a theoretical modeling study, but still, it's good to think about what may happen in the future. I didn't put down a slide of future research or ongoing research. There's some very nice theoretical things that have arisen from this work. For example, one of my PhD students is currently working on the problem of imputing missing data. So your smartwatch is off being charged. I don't have data for you. Or your smartwatch ran out of battery because whatever, and we don't have data. How do you impute the missing data? Well, let's say I'm missing some heart rate data. This is a univariate time series, but I do have some information. I know that heart rate varies by hour, by hour of day, or just which hour it is. It varies by day of the week. It might vary by week of the month. It might vary by month. So there's temporal patterns. And so our student is developing an imputation method that examines the temporal dependencies and then uses key temporal dependencies to impute missing data. So there's some good other theoretical work that I didn't put on a slide, but is interesting. But in conclusion, though, and this study was published in, that's typo, PNAS Nexus, just like last month. And this is the figure the journal made up, which I thought was super cool. I want to thank my collaborators at Tel Aviv University, Dan and Erez, who are professors. I work with this guy, Martin Nadifo, Texas A&M, and Mart Vessenerm, who's a PhD student at Aalto University. So thank you very much, and I welcome any questions you may have.
All right, any questions for Professor Brandeau? Great, you guys are even close to each other. It's fantastic.
Yeah, I can.
Okay, sure.
Sure, thank you. That was so nice. Great presentation. This was really fascinating, and I wear a Garmin. I'm kind of disappointed I don't get these kinds of alerts. My question is about kind of the bigger picture and the system, thinking about layering smartwatch alerts with other precautions. I mean, some of them could be like hand washing campaigns and other public safety campaigns, as well as like physical, like improved airflow in buildings and whatnot. And what's kind of the practical takeaways when you think about it that way?
The practical takeaways, you could have even more benefit if you could have behavior change beyond just have fewer contacts per day. Yeah, I think that would be really interesting to model. I just think there are a ton of behavioral issues that we haven't even begun to explore here, right? Yeah.
Yeah, I agree. It's a great presentation, an amazing study, complimentary. I have more micro questions, not big picture questions. For the first project, I see that you assumed the mean incubation period for estimating, and it's probabilistic, right? Like for COVID from 2 days to 10 days. Yeah. Did you do like a sensitivity analysis on what if you use the stochasticity rather than the mean values in your estimates? Does it change anything?
It will give you more stochastic noise.
Yeah, but like the estimates on the contribution of the, smartwatch early detection.
In the estimation of when you got infected, I don't think we varied that stochastically. Okay. We varied almost everything else, but not that.
Okay, yes. But if, let's say, for COVID, it's not 5 days, but let's say 4 days, you're going backwards, would that change things a lot? Or even if you do just deterministic sensitivity analysis, do you think that it would have changed your findings?
I mean, if you can only detect infection later than you thought you could, because you actually got infected 4 days ago, not whatever, yes, then it would be less effective.
Okay.
Yeah.
So for the second project, I have 2 questions. One is I see that you have a nice stochastic model. You do the simulation. Is it possible to solve it analytically if you assume a simpler, like not a gamma function? Gamma probably you can't do with viral, but let's say you go with an exponential or y, but like a simpler function for viral load. Would there be a closed form solution for R not to the, you know?
Haven't really thought about it, but it would probably be a really good PhD student project, seriously, to think about. No, I mean, I like it when there's closed form solutions.
Yeah.
We literally just published this study, so I haven't even thought
Probably
about
they
it.
would.
But that is a really great question to ask. Like, is there some functional form of that infectivity that will allow me to solve this in a closed form?
They probably wouldn't publish it if you have a closed form solution. Probably
Well,
too much math.
Journal.
Yeah, different journal.
journal.
One last question about the second project is there any dependency on the actual absolute number of contacts per person? Because interesting, okay.
No, because I'm only reducing it by beta.
But
it's whatever you did to be infectious. Whatever you did to be infectious, I'm just reducing it by beta. Your infectiousness is just out there, and I'm just going to reduce it by beta, the amount you change your contacts.
But let's say, you know, you have an epidemic in Manhattan versus, you know, rural Dakota, not Wisconsin, and then, you know, people there,
people have different infectivity depending where
because
they live.
you know they have different number of, because you are talking about close contacts, not like
I mean how many people you're going to infect.
You have like less than we
didn't think about that.
I'm very very
Again,
interesting.
This was pretty high level and aggregate, but it would be nice if you, but you know, again, you can't know. It's so hard with infectious disease. Who infected you? Was it that person or that person? And when did you get infected? I think if you had better data, though, you could really answer some pretty interesting questions. Yeah.
All right. No, cool. Thank you.
All right, great. Any other questions? Oh, lots of questions. Fantastic.
I have a chance to ask.
Oh, okay. Sure.
Hi, my name is Monica. This isn't like a question per se, but I guess in the same vein of trying to detect earlier, I guess that could potentially serve as a marker for starting to disperse like tests earlier and trying to get people tested earlier, because we do know that that is the one thing that will get people to stop contacting other people. And
testing, for example.
Yeah, exactly. Right? So I remember during COVID them sending out tests just sporadically, but I think using this kind of information would be really informative to stop the spread of disease.
And I think in the clinical trial, people had home tests for different things, which made it really nice, right? But I don't know about you, I don't have a home test for flu or strep. Well, I think they only had a home test for flu and COVID, not for strep. You had to go to the doctor for that one. Yeah.
We have time for one more. Oh, great. Good.
Thanks for the talk, Professor Randall. My name is Minghua, and I have questions regarding your second part of your presentation. So my question is, if you have access to like personal data, like because everyone wears their own watches, personalized data, I'm wondering if there's any benefit if there's any chance using like personalized information to predict how long disease would. Like, because in your project, in your stochastic model, you use the means from all those studies for all the diseases, the R value. Is there any chances using personal data to give a more accurate picture of those parameters instead of only using